This video demonstrates the resection of a rare intramedullary neuroenteric cyst, which had a persistent neuroenteric canal and a defect in the vertebral body. The procedure was performed using a unilateral transpedicular approach, involving both extradural and intradural corridors. The author declares no conflicts of interest or any other relevant disclosures. The young man, aged 26, came with a complaint of persistent dull aching pain in his upper back for a duration of 2.5 years. Over the past year, he had been experiencing a gradual and worsening spastic weakness in both of his legs. Upon examination, his strength in the lower limbs was 4 by 5 on both the sides, and he exhibited extensor response in the plantar reflex. Additionally, he displayed a sensory loss of around 20 to 30% below the level of fourth thoracic vertebra. On MRI examination, a defect was observed in the vertebral body at the level of D4, through which a cyst protruded, extending into the prevertebral space. The cyst displayed a continuous connection with the ventral cerebrospinal fluid space at the same level. The content of the cyst exhibited the same signal intensity as CSF on both T1 and T2 weighted images. Additionally, a cord-like structure was visualized extending from the cranial end of the cyst. This structure extended in a cranial direction, positioned ventral to the spinal cord, and was attached to it at the D1 level. At the most cranial extremity of this structure, another intradural cyst was observed, with evident cord expansion. This cyst appeared hyperintense on T2 weighted sequence. Notably, there was no contrast enhancement. The cyst that herniated through the vertebral body defect was found to be associated ventrally with the azygous vein, esophagus, and the descending aorta, evident on axial cuts. Thus, the preliminary preoperative assessment identified a D4 neuroenteric cyst. With the patient placed in a prone position under general anesthesia, a linear incision was made along the midline. Exposure of spinous process and lamina spanning from C7 to D6 was done. Subsequently, laminectomy was performed. On the right side, further lateral exposure was done to expose the D4 pedicle. The dura mater was gently retracted medially to reveal the protruding cyst, thereby confirming the precise level for subsequent exposure. The ventral venous plexus was cauterized and incised on either side of the D4 nerve root. The dura mater was medially retracted to access the ventral wall of the cyst. Careful separation from the bone allowed for the exposure of the edge of the vertebral body defect. Using a 3 mm cutting burr, the medial aspect of the D4 pedicle and the lip of the vertebral body defect were drilled to expand the posterolateral corridor to the ventral dura. From the right-hand side, utilizing the now expanded posterolateral extradural corridor, the cyst was meticulously separated from the adjacent soft tissue. This dissection involved a combination of gentle, blunt dissection and precise cutting of the dense fibrous tissues. Special attention was directed towards preventing any harm to the underlying structures, including the esophagus, azygous vein, and the descending aorta. Once the extradural dissection of the cyst wall was accomplished, the intradural exposure was initiated. A midline incision was made in the dura mater, and dural sutures were placed to ensure sufficient exposure of the spinal cord. The dentate ligament was incised, and the spinal cord was gently retracted to uncover the inner lining of the cyst. The cyst lining exhibited a grayish hue and contained a cord-like structure indicative of the persistent neuroenteric canal. This cord-like structure extended cranially within the dura mater, positioned ventral to the spinal cord. It was firmly adherent to the cord's ventral surface, necessitating careful traction and gentle blunt resection for separation. At the cranial-most end of the persistent neuroenteric canal, that is, at D1 level, a cyst with milky content was seen, which correlated with the preoperative radiology. The cyst was exposed by sharply cutting the overlying arachnoid layer and dissecting off the traveling nerve roots from its surface. It was the possible cause for the recent onset paraparesis due to the mass effect on the cord. It was compressing and intruding into the cord medially. During this process, the cyst ruptured. The contents were sucked, preventing any spillage into subarachnoid space. The remaining cyst wall was then excised. Continuing from the right-hand side, dissection of the persistent neuroenteric canal was initiated, detaching it from the cord's ventral surface in a cranial direction. Upon reaching the D1 level, the canal transitioned into a intramedullary position. At this juncture, the canal was initially resected, followed by precise incision of the remaining stump that was connected to the cord. However, due to the potential risk of causing harm to the spinal cord, no further endeavors were undertaken to explore the intramedullary portion. Subsequently, the excised canal was maneuvered towards the cyst, where its continuity and fusion with the cyst wall became evident. The cyst-dural junction was identified. Employing a number 15 scalpel, a circumferential resection of the cyst was performed. The cyst, together with the persistent neuroenteric canal, was successfully removed in one piece. The defect in the ventral dura was addressed using synthetic dura material. Subsequent dural closure was done. Additionally, another piece of artificial dura was positioned as an overlay to reinforce the repair of the ventral dural defect. Post-operatively, there was improvement in lower limb strength. Nevertheless, the patient required clean intermittent catheterization for urinary retention until the sixth day after the surgery. Subsequently, the urinary symptoms gradually abated. During the 6-week follow-up, the patient exhibited complete resolution of myelopathy